go ahead and get started. Welcome to the Gold Star Medical Billing School. Today's modules that we'll be talking about for the webinar this evening are going to be dealing mainly with the patient side of collections. And so even though as a medical biller your primary concern is with insurance collections, it's very, very important as a medical biller that you have a good handle on patient collections and what the patient portions of their payment should be. And the reason for that is because nowadays the patient part of the medical bill is usually higher than the insurance part, and so if you don't know how to properly advise your clients or your doctor on what to collect from the patient, then you are you're really leaving a lot of money on the table. So what we're going to talk about first with respect to patient collections is the procedure and system for conducting insurance verifications at your office or insurance verifications on behalf of your client. Now, for those of you who work with Gold Star or work as a Gold Star rep, for those of you who are thinking about becoming a Gold Star rep or aspiring to become one, I will tell you that the position of an insurance verification specialist is a specialized position, and so we actually hire people to do nothing but insurance verifications. So as a biller with Gold Star, you won't necessarily be responsible for doing insurance verifications on your clients. That's going to be something that will be carved out to the insurance verification specialist. However, you will have to do them from time to time if your verification specialist is on vacation or out of the office, if they're out sick or whatever. And so it is important that you know how to properly conduct insurance verifications. So let's go ahead and get started talking about insurance verifications and why, first of all, they're so important. The one thing you need to understand in the insurance climate that we live in right now, the reimbursements from insurance companies only make up between 30 and 50% of a doctor's total fee for service. So, for example, if you were to bill out $100 on a service code, and on the national average, if the doctor is in network with a particular insurance plan, that $100 is only going to be paid at about $70. So usually there is anywhere from a 30 to a 40 or even higher percent write-off between what the doctor actually bills out to the insurance company and what the insurance company actually pays, takes their payment based off of. So you have the insurance reimbursements only making up a small percentage of the doctor's total fee for service. So, going back to that $100 that your doctor bills, if the insurance company asks for a write-off between what was billed and what the contracted allowed amount is, let's say that's 30%. So that would be a $30 write-off. Well, that leaves $70 that is payable to the doctor. And of that $70, the remainder of it is usually split between the patient cost and the insurance costs, and it's called a cost share. And so the insurance company isn't going to take that $70 and pay that at 100%. The patient is probably going to have either a copay or a co-insurance, which is a percentage of the fee that's allowed. They may even have a deductible to meet. So in some cases, that $70 that's billed will receive no payment from the insurance company as a patient is working on their deductible. So anyway, you just need to make sure that you understand that if you don't know or your office doesn't know what to collect from the patient at the time of service, the doctor could be losing up to 50% of their fee. And it's always easier and less costly for the doctor to collect from the patient while they're at the office at the time of service than to bill them later. And what do I mean by that? You know, I use this this little chart in many of my webinars and many of my presentations, and the reason why is because it's so important. If you take $1 and you were to let somebody walk out the door without paying that dollar, over a certain period of time, it begins to devalue, and for many reasons. So if this was actually a study that was conducted by the Commercial Law League of America. They investigated over 50,000 businesses and polled them as far as what their accounts receivables were worth after 30 days, 60 days, 90 days, 6 months, and 1 year. And this is what they found, was that any dollar that went over 30 days had already lost about 7 cents on that dollar. After 61 days, you'll lose about 15 cents on the dollar. After 91 days, you're losing about 25 cents on the dollar, and then it really starts to go down. After 6 months, your dollar is worth about 50 cents, and after a year, it's only worth about a quarter. So take that dollar and multiply that by 10,000, and now you're looking at $10,000. If you have a $10,000 accounts receivable that is over a year old, that $10,000 is worth, if you're lucky, about $2,500 now. And that would be in healthcare. Over the years, as I've experienced billing and collections and revenue cycle management, these numbers ring very true, because the longer a patient goes without paying their bill, or the longer an insurance company is out there without a claim being settled or paid, it takes more staff time, and so of course the cost of the staff, the cost of mailing out statements, the cost of sending out claims and paying a clearinghouse to sort those claims and rebill those claims, and the staff hours that it takes to follow up on claims that haven't been paid, the staff hours that it takes to to send out those patient statements, the postage costs, and so on and so forth. All of that factors into the devaluing of that dollar, and even more so, the trying to track that patient down after they have left the building to get them to pay that bill. It becomes more and more difficult. You know, the old saying is, you get them while they're hot. You get that patient to pay their bill while they are standing in the office, and then you don't have to worry about this level of devaluation of your dollar. So how do we do that? I mean, how do we know what to collect on patients? And really, one of the best ways to determine what a patient should be paying at each visit is to do and conduct an accurate verification of benefits. And so insurance verifications can be conducted in many different ways, and we'll talk about that here tonight. But first of all, you most certainly want to check benefits on any new patient that walks through the door. So if a patient comes in and walks in with an insurance card, or they schedule an appointment and they indicate to you that they have insurance, then it would behoove your office or your doctor's office, if you're a biller, to check those benefits before the patient even comes through that door for their first visit, or if at all possible, before they leave from their first visit. You also want to check benefits on all established patients who've not been seen in the office in at least 6 months. And in actuality, for in this day and age, if you know a patient has a plan that is sponsored through the healthcare marketplace, through the Affordable Care Act, they should probably have their benefits checked every month, because these patients pay their premiums on a monthly basis. And so if they miss a month of premiums, they're given a 90-day grace period to catch that up. And if they don't catch it up, then their their insurance terminates, and anything that was paid out during the time that they hadn't paid the premium is recouped back. And so you have to be careful about that. So you may even check benefits if you know that you're dealing with an ACA plan, or if you're dealing with a Medicaid patient. Medicaid patients' benefits will change from month to month. Sometimes a patient may be eligible for Medicaid one month and not eligible another month because it's based on their monthly income. And so if you have a high percentage of Medicaid patients, it's very important for you to check their benefits, because they could walk through the door with their Medicaid card and receive services and not even be eligible. And if they leave, they're responsible for that bill, but good luck trying to get a bill out of a Medicaid patient. I mean, you know, these are people who are on fixed incomes or very limited incomes and would have an extremely hard time paying their bills. So it's super important for you to check benefits on your Medicaid patients. For sure, you want to check benefits on every patient at the start of each calendar year. Why is that? Because even though the patient may still have the same insurance policy, their plan may change. So what typically will happen is every year, for the most part, insurance benefits will reset. And so one year the patient may be paying a premium. Let's say they're paying $500 a month, and that $500 a month premium gets them a policy in which they have a $1,000 deductible, and then the insurance kicks in after the deductible at 80%. Well, at the end of the year, the insurance carrier is going to want to renegotiate that agreement, whether it's with an individual or with an employer. And so what they'll do is they'll say, well, if you want to keep the same benefits, you're going to have to pay a higher premium, which many people don't want to do. They'll say, well, I can't afford a higher premium, so if I keep the same premium, what will my benefits be? And the insurance carrier will tell them, well, if you keep the same premium, then your benefits may be, instead of a $1,000 deductible at 80%, now it's going to be a $2,000 deductible, and then we'll kick in the cost share at 70% for the same premium as you paid last year. And this is very common with insurance companies. They'll start out at one rate, and then from year to year these rates change and the benefits change. So every patient should have their benefits checked at the start of each calendar year. Now, there are certain types of patients who may have a fiscal year policy. And typically these are going to be school teachers, college students, some government workers, because the government fiscal year starts October 1. The school year usually starts August 1 for the school teachers' plans. And so what that means is, instead of having a deductible that runs from January 1st to December 31st, they may have a deductible that runs from August 1st to July 31st. And then August 1st, their deductible resets. So when you're checking on benefits, it's important to know whether that patient has a calendar year policy or a fiscal year policy, so you can schedule the patient for a recheck at the appropriate time. So we have the parameters under which you need to do your insurance verifications, and in order to conduct accurate verifications, the first steps to do that are going to be to gather up the information on that patient to allow you to check on their benefits. The second step is going to be to obtain the benefits, and then the third step is going to be explain the benefits. So you gather up the information, you obtain the benefits, and then you explain the benefits. And so let's talk about each of these steps in greater detail. First, the first set and group of information you're going to need to complete accurate verifications is coming from the patient. So you need the name of the patient, and you would need to get the name of the patient as it appears on their insurance card. This is super important. You may have a patient that comes into you, and I'll use myself as an example. I may walk into a doctor's office and say, my name is Lisa Majeski, and I'll fill out all of my paperwork that way because everybody knows me as Lisa Majeski. But on my driver's license, on my birth certificate, on my insurance cards, on my passports, my full name is Elizabeth. And so if you were to try to verify benefits on me under Lisa Majeski, the insurance company would not be able to find me. Even though all of my, I write in all my information as Lisa. Lisa is actually my nickname. Also, you may have patients who are recently married, and they may still be covered under their maiden name or their previously married name. Now they're married and they have a new name, but they haven't changed their insurance card. So these are the types of things that you have to be aware of when you're checking on benefits. You'll also need the patient's date of birth. The insurance carrier will not do any correspondence over the telephone with you or even online unless you have the patient's date of birth. Sometimes the patient is not the insured. For instance, in the case of a child or in the case of a spouse where you're checking on the spouse's insurance as a secondary policy, for example, if the insured is not the patient, then you need the name and the date of birth of the insured. You need the policy number or the ID. Sometimes you will need a group number. Most insurance cards will have a policy number and a group number. The policy number is also known as the subscriber number. So you may be asked for the subscriber number or the policy number. You would need the name of the insurance carrier that they use for their insurance, the telephone number for the customer service unit for eligibility and benefits, and you would need to know the chief complaint. Now, that doesn't mean you need to have a diagnosis, although the insurance company, when you're calling them, will ask you, well, what's the diagnosis? You don't have to give a diagnosis. You can just give a general, the patient has a headache or sore throat or possible sinus infection, low back pain, skin lesion, whatever it is. You don't have to have already had a diagnosis in order to check benefits. But you do need to know a chief complaint so the insurance carrier can have an indication as to why you're calling on benefits. Once you've obtained the patient information, then you also need the provider information that's needed to complete accurate verification of benefits. In this case, you would need the name of the doctor or the provider who's going to render the service, the name of the clinic or the organization that the doctor works under, the tax ID of the clinic or the doctor. Now, what do you get? You need the tax ID of the entity that the claim is going to pay to. So if the doctor is a solo practitioner and they bill everything under their name, their individual name, the check is going to go to the doctor, then it would be the doctor's tax ID. In some cases, the doctor will have an employer identification number or an EIN, and in some cases it may be their social security number. Would be considered their tax ID. It's much rarer now that they use the social security number. Most doctors, even if they are a sole proprietor or they're a solo doctor, will obtain an EIN or a tax ID from the IRS. And so you would normally give that to them. And if they bill under their clinic name, so let's say it's Apple Medical Clinic, then it would be the tax ID of Apple Medical Clinic. You would also need the NPI or National Provider Identifier of the clinic and or the rendering doctor who's rendering the service. And you would need to know the network or provider status. In other words, is the organization in network and has a participating PPO agreement with that insurance carrier or with that particular plan, and is the rendering provider of that organization in network. Now, is it possible to have a situation where an organization is in network but a rendering provider is out of network? The answer to that is yes, it is possible. So for example, you may have an organization, a clinic that you're doing billing for, and they recently hire a new doctor. And when they hire that new doctor, they have to go through a credentialing process to get that doctor listed under the umbrella of that organization as a participating doctor with the organization. And so during that period of time, that rendering provider may actually be out of network. So if you were to bill the claim with the organization's information as the pay to, but the doctor that provided the service is out of network, then the claim will be paid out of network instead of in network. So this is important to know. If you're a biller and you're taking on a new account, this is something that, of course, working with Gold Star, we do this when we are setting up a new client. We go through an exhaustive questionnaire with them to ask them these types of questions. Are you in network with these different plans? Sometimes they know and sometimes they don't. And when they don't know, then it will be up to you during the insurance verification process to find out. And you can actually ask an insurance carrier to check to see if the doctor or that particular NPI or that particular tax ID is listed as an in-network entity or an in-network provider. So if you're not sure, then err on the side of caution and check. Put unknown, let the insurance company know that you're not sure, and ask them to check for you. It takes a little bit of extra time, but it also allows you to accurately do those verifications. The other reason why it's important to know the network status is because just because a doctor or a healthcare organization is a PPO under an insurance carrier, that doesn't necessarily mean that they are in network with all the different contracts. So they may be in network with the PPOs, which are the preferred provider organizations, but they may be out of network with the HMOs, which are the health maintenance organizations, and that's fairly common. So, sometimes when you take information down from a patient and you don't have a copy of the card, you may not see that at the top right-hand corner of the card it says HMO, and let's say it's Blue Cross HMO, you may not be a provider with that HMO. So it would be important for you to ascertain as accurately as possible what that provider status is, because that is certainly going to determine the benefit amount and the benefit structure for that particular patient. So once you've gathered up the information, then the question is, what do you do next? And the next step to obtaining an insurance verification would be to see if you can gather up as much information as efficiently as possible. Online verifications are the fastest method to obtain benefits on a patient. And I will tell you that over the years, insurance carriers have gotten much more accurate with online verifications, to the point where under many circumstances you can obtain benefits online without having to call, which is really nice because that takes a fraction of the time as a telephone call. It's the fastest way to do it. The problem with online verifications is that it doesn't always give you detailed information about certain benefit limits, the deductible status, and so on and so forth. So for example, if you are doing billing for a chiropractic office and you go online to check benefits and you try to pull up chiropractic benefits, it may give you some general information such as that yes, the policy does cover chiropractic care, but they only cover 15 visits per calendar year, and that's fine to know. But what they don't tell you is whether the patient has used any of those visits. And if the patient comes to you in the middle of the year, let's say, and has used all of their visits with another chiropractor, maybe they've just moved into town, and they see a chiropractor on a regular basis and they used up all their visits, you wouldn't know that necessarily by the online verification. So one of the things that I recommend, a verification specialist do is have a verification form that you use. And when you do the online verifications, match the information up against your form. And if there are any blanks left on your form after you've obtained the online verification, then you would want to go ahead and make a phone call to find out the rest of the information. In most cases, certain specialists like chiropractic, dermatology, allergists would want to verify benefits live with a customer service rep over the telephone. Now, there are still a few carriers, very, very few. Medical Mutual is one of them. Meritain is another one that sometimes require you to have the verification of benefits faxed to you, and then and only then, if the information is not enough to give an accurate and full verification, on the fax itself there's a number usually at the bottom of the fax and an authorization code that you're given, and you then have to call to that number using that authorization code to speak to a customer service rep. So essentially what they're trying to do is keep their lines clear from unnecessary verification inquiries, and their philosophy is, well, if we can fax the verification and it's good enough, then they may not call. So you would have to, so in some cases you may not be allowed to call on benefits before you ask to have it faxed over to you. The good thing about faxed verifications or online verifications is if you can print those. For the faxed verifications, it gives you the fax cover sheet with the date and time of that fax. On the online verifications, the top of the form will have the website and the time that the inquiry was made. And if the verifications are outdated, then it will give you a basis for appeal. So, and this is also the danger with online verifications, is that the insurance companies don't always update the patient information, especially in the beginning of the year. Sometimes it takes them a month or two to get all of the new benefits for the new calendar year loaded into their computer systems for verifications. And so sometimes the online verifications are not, or the fax verifications aren't going to give you the most up-to-date information. But it does give you the ability to appeal that if you do print out that fax or the online verification. So the most accurate method, other than the better carriers that do have great online verifications, the most accurate method is to get on the phone and do a live verification. Now, with that said, I was talking to I taught this as a live class this past Saturday, and I was talking to the students in the class that it is not unusual for you to be in a situation where you would call for a verification, possibly not get all the information you need and realize that you have to call back. You call back to finish up that verification and you're given a whole different answer than the original verification. Sometimes you can make 2 or 3 calls and get 2 or 3 different stories from the insurance company on what the verifications are. However, with that said, by obtaining a live verification, number one, almost all of the calls are recorded. Number two is you can get a specific name of a claims rep. You can record the time of call, and you would always get a reference number for that call, so that in the event the verification is incorrect, we can appeal those claims as an incorrect verification quote. Phone verifications are also much more time intensive than the online verifications, but in many cases they're worth the effort, and they allow you to save your doctor or clinic thousands of dollars each year in lost revenue from not knowing what to collect from your patients. So if you're going to do a telephone verification, the hardest part obviously is just getting through. Before you reach a live person, you're probably going to go through some type of an automated system. And it's very rare that you just call and reach somebody at the insurance company. So you're going to have to go through all of these prompts and make sure you listen to all of them before making your choice, especially if you're new to verifications or if you don't know that particular insurance company's prompts. Many times after you go through all of the prompts, the last one will give you the option to speak with a customer service representative. Sometimes you're allowed to, one of the things that I do with verifications is if I have to do a verification, as soon as the customer service unit comes on, I'll immediately press 0 for an operator. And sometimes I get lucky and get right through to a live person, but most of the time what happens now is if you press 0 for the operator, or you say, if you're doing an IVR or interactive voice response, if you speak and say customer service or operator, you'll get a prompt back that says, we'll be happy to transfer you to a customer service rep, but first we need additional information, and you still have to go through all of the information that the insurance company wants to identify that patient. And so, but here's what's going to happen is as you do more and more verifications, especially once you start doing, let's say, Blue Cross verifications, you're calling pretty much the same number every time. You're going to listen to the same prompts, and you're going to be able to speed your way through it. You'll know that Blue Cross is, as soon as you answer the phone, you're going to press 2, 4, 3, and 7, and then you'll get your customer service rep right away. And so it's just a learning process. If there is an interactive voice response, which many insurance carriers do have for the verifications of benefits and also for claim status, it's also known as IVR, interactive voice response. Make sure you speak clearly and slowly. I was teasing my class on Saturday because we're all here in West Texas, and some of the ladies in class have very, very strong God bless Texas accents that don't do well on IVR. They don't the IVR doesn't understand the accent, and so you have to de-accent your voice a little bit in order to be successful with IVR, and speak very clearly and very slowly. So for example, remember, if you're using IVR, the IVR will do whatever you tell it to. So if you have a patient whose policy number is XGB504 and you say XGB504, it's going to put an O in place of that 0, and it's going to tell you that they can't recognize that that policyholder. So you have to make sure that if you're dealing with a number, you clearly say the number. So a 0 is a 0 and an O is the letter O if you're using IVR. So speak clearly. Make sure you don't run your numbers on to where they can't understand it. Under the IVR system also, it always works best if you have the phone to your mouth and you're not on speakerphone. Many times the speakerphone doesn't pick up your voice clearly enough to get through the IVR, and it just becomes a very frustrating process. So the IVR is something that, as an insurance verification specialist, or if you're doing insurance verifications, you have to get used to and train yourself to use the IVR and talk to the IVR the way the IVR talks to you, which is clearly and slowly. Now, if the IVR can't recognize your voice pattern, then just speak the words customer service or operator, and usually it will then take you to a live body. So again, for some common carriers like Blue Cross Blue Shield and Medicare, you'll end up memorizing these prompts over time, making the phone calls go more efficiently. And speaking of efficient, obviously with the insurance verifications, one of the things that you're going to want to do is, if you have a multitude of verifications, let's say you have 10 new patients coming in one day. Number one is you need to organize those verifications by the time of the next appointment, but also by the insurance carrier. So you may have a patient coming in at 9 o'clock tomorrow morning, and then you may have, and that patient has Blue Cross, and then you have another Blue Cross patient at 10:30, and then you have another Blue Cross patient at 3 o'clock, and another Blue Cross patient at 4:30. Well, in that case, you probably wouldn't want to go by the time of their appointment, but gather up all the Blue Cross patients all at once, so you can do one call for all 4 patients. And many times the insurance company will let you do that. Some insurance companies will limit you to a certain number of inquiries per call. I think most Medicare, you can give 3 inquiries per call, and then you have to call back, or 3 inquiries per day. But most insurance companies are pretty good, and they'll just let you stay on the phone as long as needed for you to get through those verifications. So make sure you gather up your verifications and organize them so that, number one, they're getting completed by the time the patient is supposed to come in for their appointment, but also gather all of the same policy types up so that you can make one call for a number of different verifications. When you do finally reach a live body, you're going to want to first identify yourself, the name of your clinic, and the purpose of the call. So you would say something to the effect of, "Hi, my name is Mary, and I'm with Dr. Jones' office in Tallahassee, Florida. I'm calling to check," and then you would say medical, chiropractic, dermatology, whatever your specialist is. "I'm calling to check chiropractic benefits on a patient." And then you would ask them, "May I ask your name and your employee or representative number?" So sometimes when they get on the phone, they will identify themselves. "Hi, my name is John. How can I help you?" But if you don't get their name right off the bat, which is pretty common, not to get that, sometimes they speak very fast. Sometimes they're hard to understand when they first come on the call. So you will want to reiterate their name, get the spelling of their name, ask them if they have an employee number, because there can be a million Johns in that, in that customer service unit. So ask for their employee number, and then you can move on. And so once you've let them know who you are and ascertained who they are personally, then the rep will ask you for information, and this is where the gathering of that information earlier is so important. They're going to want to know the doctor's information or your healthcare provider's information, their tax ID, their NPI, which is the National Provider Identifier, and so on and so forth. They will also then ask information about the patient, their insured, the information about their date of birth, their ID, and so on and so forth. Sometimes when you go through the automated system, if you key all of that information in before getting the customer service rep, they may already have that pulled up. The more sophisticated systems do, but be prepared to give it again just in case. And they're also going to ask for the chief complaint or diagnosis. Once they have the information from you, then they'll probably put you on hold for a brief period of time. And when I say brief, it could be anywhere from a minute to 10 minutes. It just depends, to pull up the benefits. And then what they're going to do is they're going to just run through those benefits very quickly. When you first start doing this, you're going to freak out. I'm just saying, most people, when they, and I've trained a lot of people on insurance verifications where I've sat with them as they're trying to get a verification done, and the customer service unit on the other end of the line, just they go through those benefits so fast. And here you are, you've got a form that you need to fill out, and you're trying to write as fast as they're talking, and you almost never get all the information the first time around. Even if you're extremely experienced at this, you almost never get all the information the first time around. So don't get nervous. As they are speaking, go ahead and have the insurance verification form in front of you, and fill in as many of the blanks as you can as they're talking. Then what you do is, once they have finished, then you go back to the beginning, and you would then ask them to repeat. So, Jonathan, I did not get all the information you gave me the first time around, and I still have a few more questions. May I ask them now? And then at that point, you don't ask them to run through the benefits again. You just ask them the questions that you didn't get answered. One of the most important things about an insurance verification form is that you leave nothing blank. It's either a yes, no, or unknown answer. If you leave it blank, then either your client or your doctor or your front desk person is going to assume that you didn't ask that information. And so you must never ever leave a field blank on an insurance verification form. Something should always be placed in the field. And you go through the verification form that you have, and you ask your questions. Go through it thoroughly. And if the doctor wants you, or the healthcare provider wants you to check on specific CPT codes or procedure codes, then you would also ask about that. So you would say, Jonathan, my doctor performs certain procedures routinely. Would you please check on some CPT codes for me? And then you give the claims rep the codes that you want to have checked on. Once they've done that, then you would review the information with them again. You would say, okay, going back to the beginning, Jonathan, let me just make sure I've got this all right. This patient has a calendar year policy. Their effective date was such and such a date. They are a PPO plan. It says you told me that this patient has a $2,000 individual and a $4,000 family deductible, and they have met $1,000 of their individual, but they have met $4,000 of their family deductible, and they have an 80% 20% cost share, where they're required to pay 20% of these eligible services, and you just go through all of it. So you re-verify with the verification specialist to make sure they got all that information correct. And the reason why you want to do that is because they're recording that call. And so if you say it at the very end, that recording, if they are wrong, if they give you incorrect information, then but you have reiterated that verification form, and then they say yes, that's correct, then they've essentially entered into a verbal contract with you. Okay, and once you've gotten that information and verified with the claims person that the information that you have is correct, then you would ask them for the mailing address, and in your notes put and payer ID to submit the claims, because most insurance policies now and insurance claims are submitted electronically. So you need an electronic mailing address, which is known of as a payer ID, but you also want the mailing address. And then at the very, very end, at every single call, you must ask for a reference number for the call, because that is what you will use in the event that they misquoted benefits to you. You'll need to go back to that reference number and the time and day of call and the person you spoke to, and then speak with the customer service unit about that. And then as the billers, we can appeal that claim based on incorrect information. It also lets your doctor know that, the information you wrote down on the verification form was obtained on the telephone by, with this person at this time, and here's the reference number for the call to verify that you did that work. Okay, so here is an example of an insurance verification form, and this is actually the form that Gold Star medical verification specialists use as their template for verifications. And so if you were ever to come on with Gold Star Medical and work as a verification specialist, this would be the form that you would use. We have clients who will come on board with us who will ask us if we can use their own forms, and our answer is a very polite but firm no. And the reason for that is because, number one, many of the doctor's forms aren't thorough enough, and number two, you need, as a verification specialist, to be able to learn this form and be able to go through these verifications very quickly. And if you're having to switch between 5 different forms or 10 different forms because you're doing verifications for 5 or 10 different clients, that's going to make for very confusing work for you. So what this does is this standardizes everything for our verification specialists. Now, with that said, we do have a few places on the form that can be customized, and it's typically under item 16E, where it says CPT codes. And you'll see here on this template it says, if your specialist performs certain procedures routinely, ask the claims rep to check those specific CPT code. Customize your form here with those codes, and that's where you would put the codes to check on. And so you'll notice that on this form there is a bunch of information that you have to obtain. Number one is, of course, at the very top of the form you see you have the date, the name of your doctor, the name of the insurance carrier, their phone number, the name of the patient and their date of birth, the name of the insured and their date of birth if they're different than the patient, the name of the customer service rep, the time of the call, and the reference number, okay? And then you have the information about the benefits. So, is the policy in effect? Yes or no, you would circle that. The effective date of the policy, in other words, when did the policy start? Is the policy a calendar year or fiscal year policy? If it's a fiscal year policy, then you give the start dates. When does the fiscal year start and end? And then you would ask, does this policy cover, and this is something, you would probably, for each doctor's verification form, you could pre-populate this by putting in, for example, chiropractic or ophthalmology. And if it is a family practice or general practitioner, you would not need to ask that question. However, honestly, if you're doing family practice or general practice, you're probably not going to be doing a phone verification. You're probably going to be doing an online verification because those are fairly general. Does the patient have a deductible to meet? Yes or no? And if the patient doesn't, then you can skip right down to item 10. But if they do have a deductible, then you would need to ask whether that deductible is an individual deductible or a family deductible. And in many cases, an insurance plan will have both, an individual and a family deductible. So let me stop here and give you the difference. An individual deductible is a deductible for that particular patient. A family deductible is a deductible that if every person in the entire family pools all of their medical costs and meet a certain amount, then the family deductible is met. And what that means is that every individual under that plan also has met their deductible. So let me just give you an example. I have a family. I have Lisa, Rick, Adam, Alex, and Jeffrey. That's my family. So under our plan, we all have individually a $3,500 deductible. So Lisa has a $3,500, Rick has a $3,500, Alex has a $3,500, and so on and so forth. So if Lisa meets $3,000, has medical expenses, and meets $3,000 of that deductible, Rick has medical expenses and meets $500 of that deductible, and Alex meets $3,000 of that deductible, and Adam meets $1,000 of his deductible. So individually, none of us have met our deductible. But if our family deductible is $7,000, between all of us, we've met $7,500 of a family deductible. Once all the family members combined reach that $7,000 level, then the family deductible is met, and that means that every individual also has met their deductible. Okay, so even though we didn't meet the individual deductible, we will have met the family deductible. Okay, hope that makes sense. On the flip side, let's say we have Lisa, Rick, Adam, Alex, and Jeffrey. Lisa has medical expenses and she meets her deductible, $3,500. Now Rick goes for medical and the family deductible is $7,000. Because that $7,000 hasn't been met and only my deductible has been met, then I'm the only one that gets the deductible met clause. Rick, Adam, Alex, and Jeffrey still have to meet that individual deductible. They'll still work on the deductible, but mine will be met. But once we meet the family amount as a family, then all of our deductibles are met, okay? And so it's important to ask that question because sometimes an individual will not have met their deductible, but the family will, which means that the individual no longer has a deductible for that year. If anybody has any questions about that, feel free to type that into the chat, because I know there was a lot of lively conversation about that on Saturday. Does the patient have a co-insurance or a cost share? Now the co-insurance, remember, is a percentage of the billed fee that the patient must pay as a cost share for that service, and that is after the deductible has been met. So the insurance company is not going to pay a penny until the deductible has been met. But then once the deductible has been met, then in many cases they're still not going to pay 100%. There's going to be a cost share. The insurance carrier will pay the majority of it most of the time. Something usually 80% is about standard, and then the patient has a 20% coinsurance. But we see all different kinds of cost share. So you may find a 50-50 plan where the insurance covers 50%, the patient pays 50%. You may find a 90-10, 85-15, 70-30. There's so many different schedules of cost share, so it's important to know what that cost share is. And you'll ask what the patient's coinsurance is or what their cost share is. If it's 15%, that's where what you would put down in number 11. Does the patient have a copay, which is a fixed amount per visit? So coinsurance and copay are two different things. It's important to know that because that probably is going to be on your final exam, is what's the difference between a coinsurance and a copay and a deductible, and you need to know those differences, okay? A copay is a fixed amount. So for example, if you bill out $100 and the patient has a $35 copay, they would have to pay that $35, okay? If you bill out $100 and the patient has a 20% coinsurance, then they're only going to pay 20% of that $100 or whatever that allowed amount is. Let's say the allowed amount is $100, then they'd only have to pay $20, okay? but that amount would change by procedure. So a $100 procedure would be worth $20. An $80 procedure would be worth $16 as far as the coinsurance goes. But if they had a copay, the $100 they'd have to pay $35, and the $80 they'd have to pay $35, and a $50 they'd have to pay $35. So it doesn't matter what it is, they still have to pay $35 if it's a copay. The out-of-pocket max refers to the amount that a patient or a family would have to pay out of their pocket before insurance kicks in at 100% in that calendar year or that fiscal year. So generally, what the out-of-pocket is going to be a really high number. If the deductible is, let's say, $3,000 and the family deductible is $6,000, the out-of-pocket might be something like $8,000, and that would include the deductible amounts and any co-insurances that have been paid. Once a total of $8,000 has been paid on the family, then the insurance would pay at 100%. And so, so it is important to know what the out-of-pocket max is and whether the out-of-pocket has been met, because if the out-of-pocket has been met, then all of the copay amounts, the deductible amounts don't mean anything, and everything is covered for the remainder of that year at 100%. If it's a family or general practice, you would then skip down to number 17. But if not, if it's a specialist that you're working with, then you would look and ask for limitations on the service. So you would ask, are there any limitations on chiropractic services? And if they are, then you would need to indicate what those limitations are, whether it's a visit limit or a dollar amount per calendar year. You know, for example, physical therapy, sometimes they'll pay up to $2,500 per calendar year, and you need to find out what that limit is and how much of it has been used. Sometimes there is a global fee or a daily capitation. So some insurance companies may pay up to $60 per day regardless of what procedures are done that day. So the doctor could do $65 worth of procedures or $300 worth of procedures, and still the most they'll pay is $60. So that is another type of policy provision that you may encounter. And there may be a limit on numbers of procedures per day. So for example, in physical therapy and in chiropractic, a patient may go in, let's say, to a physical therapy clinic and have 45 minutes of physical therapy exercises and 15 minutes of speech therapy and 15 minutes of occupational therapy. Well, each therapy code is billed in 15-minute increments. So 45 minutes is actually considered 3 procedures of physical therapy, and then 15 minutes of speech is 4 procedures, and then 15 minutes of occupational therapy is 5 procedures, but the insurance carrier may only allow up to 4 procedures per day. And so that's important for you to let a physical therapy office or a chiropractic office know if they perform multiple procedures, if there's a cap on how many procedures per day the insurance company will pay for. And then of course, again, in Section 16E, you would check on specific CPT codes if necessary. You would need to also ask whether pre-authorization is required for services, and if yes, find out from the insurance company what needs to be done to obtain the pre-auth and write it in. And then finally, at the very bottom of the form is the place for the mailing address and the payer ID for the claims, and then any summary information on benefits that you might want to add at the bottom of the form. So you can see that this is a very, very detailed document, and believe it or not, you know, most of our verification specialists, once you get good at this and you get fast, you can usually complete a verification of benefits in about 5 to 10 minutes. Sometimes it does take longer if you have longer hold times, but for the most part, as you become more familiar with the insurance companies, as you organize yourself, you would be able to get, if you're doing nothing but insurance verifications, you can usually do between 6 and 10 verifications per hour. And that's working very, very efficiently, having all of these forms set up individually for each of your clients as templates, and these are just some of the things, like if you were working with Gold Star as a verification specialist, we would discuss that with you about how to be as efficient as possible with what you're doing with your verifications. So these forms can be customized with, specific CPT codes, or, if there's a specific question that needs to be asked by a certain state requirement or something like that, we can certainly customize the forms for that. But for the most part, a form like this or one as similar is what you would use to check on benefits on a patient. So just some final thoughts on verifications. They can be intimidating in the beginning. I know that you need to have a cool head about you. You can't panic. You can't get overwhelmed or intimidated by the customer service reps, especially when they start quoting those benefits and they're talking so fast. It could be intimidating. Just make sure you use that form to structure your calls and go back to anything that you weren't able to ascertain the first time around, and just go very, very methodically and systematically through that form. Accuracy on these forms is much more important than speed. You're going to get faster and more efficient at what you're doing with repetition. It just is a matter of course. If you find yourself to be on hold for an excessive amount of time, and I would say an excessive amount is 10 to 15 minutes, call back at maybe at another time of day. There are certain times of the day and certain days of the week when it's harder to get through to insurance companies. Like the beginning of the month is a little harder than the rest of the month. Monday mornings are usually pretty tough because there are a lot of claims being called in and so on and so forth. And so usually right around mid-afternoon, mid-morning, mid-afternoon is a good time to do calls, or really, really early in the morning or later on in the afternoon before they close. The only thing you have to be in danger of is if you're on hold and they close while you're on hold, you're not going to get through. They don't, it's not like when you're at the grocery store and you're the last in line and then they close the checkout counter and see everybody through that's, in front of that line. In the insurance world, if they close at 5 o'clock, they shut their phones off at 5 o'clock and you're just on hold until tomorrow. So if you're on hold and you're past the closing time, you might as well just hang up, because they probably are not going to come on the phone and you're just wasting your time. Finally, don't struggle through language barriers. If you're doing live verifications, more than likely you're going to be reaching somebody who does not live in the United States and whose English is not their first language. A lot of insurance customer service units are outsourced to internationally, to countries such as India, Pakistan, the Philippines, and so these folks will tell you their name is John or their name is Mary, but it's not. You know that they have another name and they're just given an English name for the sake of spelling or whatever. If you're having a hard time understanding them, you can either hang up and try again, or you can ask to be transferred. It's okay to do that. Just be polite. Just say, I'm so sorry, I cannot understand what you're saying. Would you please transfer me to somebody else? or you can even ask to be transferred to a North American unit. Many times an insurance company can do that. Some will say, well, we can't do that, but if they can, they will, or at the very least, they can transfer you to somebody else. Sometimes they get a little bit offended by you asking that question, but honestly, if you're not going to understand it and you're going to be struggling and you're both struggling through it, you're both going to get frustrated. But if they do get offended, there are times when you'll ask to be transferred and they'll tell you sure, but they just end up hanging up on you and you have to call back. So just kind of be prepared for things like that. Those are some of the little quirky things that you deal with insurance verifications. So just be aware. And finally, you know, the main thing that we're doing here when you are verifying benefits is doing so that you can explain them to the patient. Now, obviously, if you're working as a biller with either Gold Star or working in an insurance office, that may not come to you. That may be the front desk person's responsibility, but you may be called on to train them. So, you know, we have billers, for example, at Gold Star who have been working with their client for 7, 8 years now, and they've had to, they've worked with, you know, 4 or 5 different front desk people over that 7 to 8 years. You know, we stay on, but their front desk people will leave and they'll get new ones, and so it may come to you as a biller to train that front desk person on how to explain benefits to a patient. You know, and of course these are just some of the basic things to be aware of. After, we're going to take a little break here at the end of this class, and then after the break we're going to talk about patient collections and how to talk to patients about their benefits and so on and so forth. And we'll have a few scripts for you to use and also for you to give your clients. So that concludes our portion on the insurance verifications. I'm going to, I believe everybody is off mute, so I'm going to go ahead and take any questions that you may have right now. Okay, so we're going to get started now with the patient collections portion of this class. And again, I can't stress to you how important it is as a biller to have a handle on the concept of patient collections, because one of the things that I talked about on Saturday when I was discussing this with my class is that when I first started in medical administration, working in the billing office in 1982, you know, this was a time in medicine where insurance was pretty much in its infancy from the standpoint of medical, you know, medical claims being paid. And so insurance was very simple back then. You had essentially an insurance policy, and that policy, you had a deductible and a co-insurance. Usually that deductible was, you know, $500. That was a pretty high deductible. Some deductibles were like $50 or $100. And then usually there was a cost share between the insurance company and the patient of, the standard was 80-20, where the insurance would kick in and pay 80% of the fees that were billed and the patient would pay 20%. And so back in the day when, you know, when this all first started, the bill was the bill. And so if the doctor billed $100 out to the insurance company, they were going to get paid based on $100. Well, nowadays that's simply not the case. Nowadays with managed care, if you bill out $100 to an insurance company, if you are in network with that insurance plan, that $100 is going to be discounted down to the contracted rate. Let's say it's $70. Well, now you're going to get paid from the insurance company based on $70, not $100 that you billed. And so then you're going to have the cost share or the copay. Now, back in the day when I first started, there was no such thing as a copay. Everything was a co-insurance. So every procedure had a value. It was called fee for service. And then that value was face value. So whatever whatever was billed for that service was the value of that service. Now, there were doctors who would try to overvalue claims, and so a concept in the 80s was developed called UCR, which is usual, customary, and reasonable. And so insurance carriers would use the UCR rates, meaning whatever was usual, customary, and reasonable for your area to bill for that service. So, you know, if the $100 that the doctor billed was significantly above the UCR, then the insurance company could take it down to the UCR rate. But it wasn't a contracted rate with the doctor themselves. It was just a regional amount that there were companies that would maintain these UCR rates. One was called fee-fax, and so doctors and clinics and hospitals and insurance companies would look to fee-fax for the UCR rates. But essentially the fee was the fee was the fee. So if you billed out $100 and you had an 80-20 cost share, it meant the insurance company was going to pay $80 and your patient would be responsible for their 20. Well, many doctors back in that time felt that once the patient paid their deductible up front, they paid their $100 or $200, and the insurance began to kick in, they weren't so concerned with the rest of the money. And many doctors, in order to enhance the patient experience, so to speak, would let the patients know that, well, you don't have to worry about that copay. You know, we'll just take what insurance pays, and they would routinely write off those copays and practice a technique called NOOPE, N-O-O-P-E, or no out-of-pocket cost. And so these NOOPE doctors would essentially, you know, be very, very happy with the 80% they collected from the insurance company. Well, you know, the way it is now, there is no such thing as being happy with that 80%, because that 80% isn't 80% of what you bill. It's 80% of what the insurance company allows based on the contract. And so the doctors cannot afford anymore to live on just the insurance reimbursements. They must turn to the patient for the cost share. And so, again, reiterating this same slide that I showed you earlier on the importance of timely collections, this one it's a little bit bigger, it's a little easier to read, but you can see how that dollar devalues if it is left uncollected over a certain period of time. Right now, nationally, in many clinical settings, collections from insurance represent only about 35 to 40% of billed services. 25 to 30 years ago, this was closer to 80%, which is why doctors were able to routinely write off or discount those copays and those, not the copays, but the coinsurance amounts. And so, but if you're only getting 35% of your reimbursements from insurance, that means that the remaining 65% of all the rest of the billed services is coming from the patient. Now that 65% includes your self-pay patients, ones with no insurance, and then ones with insurance that have to meet deductibles and copays and coinsurance amounts or their cost share. So the question is if you or your doctor ran a monthly collection report, would 65% of all the collections that are coming into your office represent cash patients insurance patients non-covered and insurance patients non-covered amounts, in other words, cash. And in the first quarter of every year, this amount can go as high as 80% due to the collection of deductibles, because deductibles usually reset at the beginning of the year. So, in January, if you have 80% or 90% of your patients working on deductibles, chances are they haven't met that deductible the first time they come to see you or the second time they come to see you. Some patients never meet their deductible because they're relatively healthy and they have a high deductible. So you may have patients working on deductibles throughout the year, but in the beginning of the year especially, it's very, very important that those deductible amounts are collected, because otherwise what you're going to find happening is you're going to bill out claims to the insurance company, and you're going to get a big fat zero pay EOB or a remit that says we're not paying anything because the entire bill went to the patient deductible, and you need to look to the patient for that money. And if you didn't do the verification of benefits and you didn't make arrangements to collect that money up front, or at least make arrangements to collect it as soon as it comes due, then you're going to find yourself in a really, really significant cash flow crunch. So one of the things I like to talk to doctors' offices about is that collections is really a team effort. I know that many times doctors will put all the responsibility for collections on the insurance department and the front desk. And while everybody has their part and does their part, everybody in the office is contributing to healthy front desk, healthy patient collections. And that includes the doctor or provider. The doctor helps in collections by providing that insurance department with good and timely information on services that are rendered, accurate diagnosis codes, and making sure that they have documentation that supports the services that are being billed out. Because if they don't, then what can happen is on audit, all that money that is paid to you by the insurance company can come back because the provider has not done their due diligence in producing a good, concise SOAP note or operative note on that patient encounter or that patient procedure. The insurance department is responsible for keeping the cash flow steady with timely filing, follow-up, and appeals of insurance claims. They will also be responsible for coordinating and advising the front desk on what to collect from patients. So if let's say the insurance department is handling the verifications and maybe handling pre-authorizations, they are going to be in constant communication with those front desk people on letting them know what needs to be collected, whether that is a note in the patient account or whether that's physically talking to the front desk at the beginning of each day and saying, hey, you've got this many patients on your books. I just went through the appointment book, and on these 3 patients, you need to make sure that you're collecting a little extra money because they have a past due balance. And so as the insurance department, and even as a medical biller with Gold Star, if you're either listening in as a medical biller or you're going to be working as a medical biller with Gold Star, looking at that doctor's appointment book every day and looking to see who is scheduled to come in will help you communicate with your doctor every morning on specific collection duties that you want them to perform. So, it's always a good thing to look at that appointment book every day and see who's coming in so you can try to collect that money from them. The front desk, of course, from the patient collection side, has got the majority of the responsibility of collecting those copays and the cost shares or the coinsurance amounts, collecting for non-covered services and deductible amounts at the time of service if possible. Now, healthcare providers, HCPs, that stands for healthcare providers, their role in collections should be very, very limited. And one of the things that as a biller personally, and having trained many billers over the years, that really will get under my skin is when we as billers try to do a great job, or your front desk people try to do a great job in collecting from the patients, and then the doctors get involved. And here's how it happens. It's very easy because doctors are the healers in the clinic, and they want to make sure their patients are happy, and they want to, they don't want to lose anybody over money. And so if a patient indicates that they are going to have a hard time paying their bill, or they're going to have a hard time with their treatment plan, or whatever the case is, the doctor may, sometimes intervenes and says, well, you don't have to pay today. Don't worry, we'll figure out something. You can make payment arrangements, or I'm just, I won't charge you for this therapy today, or, there are certain things they won't charge for. They'll give away services. And as a biller, that's very difficult for us, because we know how to handle it. We want to ensure that our doctors are receiving the compensation for the valuable care they're giving their patients. And sometimes when the doctors or the healthcare providers get in our way, it makes things very tense, let's just say, amongst the billers and the doctors. And so, for me as a biller, that's one of my biggest pet peeves. Is I tell my doctors, I won't tell you how to diagnose a patient. You don't tell me how to collect the money. I'll take care of the money side of things. You just feel free to treat the patient the way you see fit, the way whatever you feel is medically necessary for that patient to have. Don't worry about what it costs. We'll take care of that for you, okay? So if the doctor is confident about that, then they can, if the patient wants them to intervene or starts crying to the doctor about how little money they have, or, I don't understand why this is so expensive, or whatever the case is, then the doctor can take an attitude. Now, of course, they don't say this outright of I don't know and I don't care, but basically the doctor takes the attitude of, hey, that's not my department. My department is to get you better and to help you feel better and to heal you. The money side of it, I leave that entirely to my staff, but I will tell you this, they know what they're doing. They will do everything they can to ensure that you can receive and afford the care that you need from me. We'll work it out, but I will have to defer that over to my staff. And that should be the end of a financial conversation that a doctor has with a patient. The doctor should never, ever be talking finances with the patient. It basically places the doctor down a level from being the doctor, which is up here, which is at a higher level than being like a merchant. It's like you're playing let's make a deal with the patient. So we don't want the doctors to do that. And then as long as the doctors do that, and then give the staff good data with which to bill insurance carriers, then you'll see that the claims will begin to get billed out. Now, in this particular slide, it says something about a checklist. I typically will go over the checklist when I'm doing this class for doctors. Since I'm not doing this class for doctors, the checklist is not included on this particular presentation. If the doctor is a solo practitioner, and let's say the doctor is brand new in practice, and they don't even have staff yet, and believe it or not, there are a lot of doctors, solo practitioners out there that still work just by themselves in the office. Or it may be just them and a nurse, and they don't have a staff person. They outsource everything else. They have somebody answering the phones off-site, and they have a billing company taking care of their billing. And so sometimes they do that, but my recommendation is that as soon as possible, bring on a competent staff member who's comfortable with patient collections. And they'll feel much better about treating patients if they keep their hands out of the finances, because those solo practitioners are treating the patients and then they're having to go up to the front desk and, and have the patient write a check to them. And that just to me, that's just not professional. And so solo practitioners really need to have an office staff, at least one person as their office staff, to handle those types of things. At this time, nationwide, it's estimated that clinics will fail to generate 25% or more of their potential income due to uncollected patient receivables. And that's pretty significant. So here are some of the reasons why. Number one, when I go into a clinic and I'm doing a clinical evaluation on that practice, so I'm looking at everything from their front desk operations to how they triage their patients. I'm looking at their compliance and their billing and so on and so forth. When I talk to front desk people, or when I talk to them about why are their patient collections so low, these are the main reasons that I'm given almost every single time. The front desk person will say, well, I go and look in the patient account and I don't know what to collect, so I'm afraid to collect anything. Or the front desk person has a what we call a poverty complex, where maybe they're young and they're fairly new at this whole thing. They're not highly experienced, and so they don't want to get the patient mad by asking them for money that first of all, they're not sure if the patient owes, and secondly, they feel like, my goodness, this is such an expensive procedure. How can I ask for the patient for something like this when I couldn't afford it? Okay, that's in a nutshell what a poverty complex is. Sometimes the office themselves don't have a good financial policy of what is expected on payment from patients and even insurance carriers. And so you go into the patient accounts and, this patient has this deal and this patient has another deal, and there's too many deals being made with patients for the front desk to even keep up with what you're supposed to collect from whom. Unfortunately, there have been situations where poor customer service is a reason why patient collections suffer. Doctors' offices that make patients wait 2 hours for an appointment, and or don't give them opportunities to reschedule. They're sitting there for 2 hours and they're being ignored, and they feel like their needs aren't being met, and so their response is, I'm not paying my bill. Why should I pay for that? It's just not worth it. And then the final one is poor payment habits of patients. Sometimes the doctor creates a monster, and then they want to change it, but they have a bunch of patients who are used to not having to pay their bill at the desk, and they're not used to having to pay their copay or their deductible, and now you're looking at this and saying, wow, I really have to do something different. How do I turn things around? So these are the main reasons why patient collections will suffer. So what we're going to do for the rest of the evening is we're going to talk about these problems, and we're going to talk about how to overcome them. And so the first problem that we talked about is the front desk not knowing what to collect. So if the front desk doesn't know what to collect, my solution is to collect something, even if it's not the exact amount the patient owes. What do I mean by that? So let's say a patient has a deductible, and you know that the patient needs to meet their deductible, but you don't know what the deductible amount is going to be for each procedure because you don't have the fee schedule. So meaning, let's say the doctor does a procedure and the bill is $100 that's going to be billed to the insurance company, but you know that the doctor is on that PPO and the doctor is going to have to take a discount off of that $100. But you don't know exactly what the discount is, so you're afraid to collect anything because you don't want to overcharge the patient. In a case like that, as long as you're allowed to collect up front, and you should always check your doctor's managed care agreements to see if you're allowed to collect for deductibles and coinsurance amounts up front. Figure out an acceptable percentage, and usually what I do is recommend about 70% of the billed fee. So if you don't know what the fee schedule is, but you know there's going to be a reduction, and you know that the coinsurance amount or the deductible amount is going to be based off of the allowable fee, not the billed fee, then what you would want to do is figure it on just a percentage of that fee. So again, using the $100, you would say that you're going to base the collection on $70. So if the patient has a full deductible to meet, and they haven't met any of their deductible, and the deductible is $2,000, then that entire $100 bill is going to go towards deductible, but it's going to be after the discount is taken. Well, you don't know what that discount is, so you just average it. You say it's going to be around a 30% write-off, so that brings it down to $70. So what we're going to do today, Mr. Patient, is we're going to collect $70 towards your deductible. The bill is $100, but we're going to collect $70 towards your deductible today because we know that the doctor has a contract and there's going to be a bit of a little write-off. At least this way we're collecting the majority of your fee, and you won't be stuck with a big bill in a month or so. So we'll just collect that $70. Let's say they've met their deductible and it's a coinsurance, and it's that $100 billed fee, but you're going to bring it down to that $70 rate, which would be about what the rate would be after the write-off. And then let's say that the coinsurance is 20%, so then you would say, well, we're going to go ahead and collect $15 today, because 7 times 2 is 14, so that's pretty close. So we're going to go ahead and collect $15 today as your coinsurance, and if it's a little bit more, we'll catch it at the end, and we'll send you a bill for the little bit that's left over. And if there's a little bit of a credit, then we'll either apply it to your next service date, or we'll go ahead and promptly refund you for that small credit. But at least you're keeping your bill manageable. So collect something, even if it's not the exact amount they owe. Always check the managed care agreements to see if you're allowed to collect up front. There are certain managed care agreements that will have very, very specific language prohibiting the doctor from collecting on deductibles and coinsurance up front. Now, that is not a copay. A copay should always be collected up front, and as a matter of fact, most insurance managed care plan contracts tell you that you should collect the copay before you see the patient. So, I know a lot of doctors that wait until the patient is finished with their visit to collect the copay. Most managed care agreements require the copay to be paid before the doctor even sees them. And you should check your managed care agreement for that to see if that is a provision in the managed care agreement. If it is, that's something that you should be doing, is collecting the copay up front. And the reason for that is because if a patient cannot make their copay, then under that circumstance, the doctor has the right to reschedule the patient if they can't pay their copay up front. But for a deductible and a coinsurance amount, and we're going to be talking a lot more about this in our compliance webinar, which will be in the next couple of weeks. I'll be doing the webinar on compliance. If there is a prohibition against collecting for the deductibles and the coinsurance up front, then you must not collect until after the insurance is billed and you know what that amount is. But what you'll find under most insurance plans is that it's not that they're prohibiting you from collecting that deductible, but they may say, there may be wording in the contract that says, well, it's not recommended and the reason why they don't recommend it is because you don't know what the allowable is, so you can't do it to the penny. But that doesn't mean it's not allowed. It just means it's not recommended. That's why you would want to go ahead and make sure that you have, do it off of a smaller percentage, so you don't have these patients making huge overpayments to their account and then having these big credit balances. You want to be as close to the exact as you can, but you don't have to be exact to the penny. Now, if you cannot collect up front, you need to have a way to secure payment for those services. So if your managed care contract prohibits you from collecting up front, what you should do is have it as standard operating procedure, have the doctor obtain or the doctor's office obtain a credit card on file, and that credit card is then stored in a very, very secure compliant database, PCI compliant database, that is accessible only to usually the office manager. And the instruction to the patient is that they're going to take your credit card information. Once the bill is run through insurance and it comes back to your office with an amount that goes towards the deductible, that you will send the patient a statement for that amount immediately, and if they don't pay it by the next statement cycle, you'll automatically process that credit card. Okay? And so this way you have a guaranteed form of payment in the event that the deductible cannot be collected up front, or you failed to collect that deductible up front. This is a very, very common practice in medicine. It's actually a very common practice now in many, many businesses. If those of you have ever been unfortunate enough to get into trouble with paying a credit card bill and you had to set up payment arrangements, basically the credit card company lets you do it, and they tell you, we need to have, to set up 12 monthly payments for your bill, and we're going to take this much out on this day, and you either have to give them a credit or debit card on file from the bank, or give them the bank routing number, the bank account information, so they automatically withdraw it. They don't send you a bill. They just automatically withdraw it. So, patients by and large are pretty used to this. What most of the doctors that I've ever worked with find is that they think that the patients are going to be uncomfortable with it, but when you explain to them that the credit card would only be used in the event they don't pay their bill, they're usually pretty good about leaving it on file. And of course, you assure them that they are, that they're in a very compliant database. I'm actually going to escape out of this and show you an example of one of these. This one is very, very popular in chiropractic clinics, but actually I personally use this also for my doctors. When I have clients who need to pay their bills, when we invoice the Gold Star clients, we basically tell them that we're not going to send them, we're going to send them a bill, we're going to give them X number of days to pay their bill, and then if they have no dispute on the bill, then we're going to go ahead and just process that automatically. And we use this cash practice system, and I know that more than chiropractic offices use it. There, this particular website is for dental offices and other offices, but you can use the cash practice system is very common with doctors' offices. It talks about being PCI compliant, meaning that this is a very secure database. If I was to sign in, I have to go through a multi-factor. I can use my username and my password, but if I was to sign in, which I'm not going to do, it would ask for another form of identification. and another password system in order to get in there to even be able to view these credit cards. And so this is like I said, this is a great way for you to do automatic payments. You can actually set patients up on a schedule of payments. So you can say, let's say the patient, you can either do a one-time payment against their deductible, but let's say the patient can't afford all their care all at once, and you wanted to set them up on a payment plan where they pay, for 4 equal payments. They pay it out over 4 equal monthly payments. You can set this up in Cash Practice and take their credit card information or their bank account information. It can also be an auto debit from their bank account, not even use a credit or debit card. And then what would happen is it sets up a schedule, and when it's time, the Cash Practice system automatically runs that credit card for you. And so you don't even have to do anything. And then if for some reason there's not enough funds in the credit card and it's declined, then you get an email letting you know that there was a problem with the payment. If there wasn't, then you get a receipt saying that the payment was taken. So this is a wonderful, wonderful tool to help with patient collections, is a tool such as Cash Practice. All right, let me get back to the presentation. So collect something. The next, this also goes along with the front desk not knowing what to collect, and sometimes the front desk doesn't know what to collect because there's not a good system for letting them know and informing them. So a solution to that would be to pre-verify benefits or pre-cert benefits before the office visit, and this is done during the scheduling process. So if the front desk just changes their procedure a little bit and has a form of the front desk, after they've scheduled the patient, they can ask the patient, do you have insurance you'd like us to check on for you? And if the answer is yes, you can use that little form to take down some basic insurance information, have the billing office or the biller call on benefits, and then you have all that information prior to the time the patient even walks through the door. You can also suggest to your doctor that they put a form on the doctor's website that a patient can fill out to request a benefit check, to request whether their insurance would cover certain services at the doctor's office. Make sure that front desk staff has access to the online resources that gives staff members the ability to log in and do a quick pre-verification. If a phone verification needs to be done for more detail, that's fine, but especially for that first visit, the main thing is knowing whether the patient actually has the coverage they say they have, and that the patient, if the patient has a copay or something that needs to be collected at that first visit, you can at least get that information from an online verification, a real quick online check. And so I'm going to, again, escape out of here. Let's go to, for example, I'm going to get out of this and let's go to Blue Cross of Texas. And you'll see that there are, here's the Blue Cross Blue Shield Association official site. So, and you'll notice that there are, that there's sections for patients and sections for providers and so on and so forth. And so, this would be the provider section where they can locate doctors, and I'm not in the right place here. Normally you can get to a provider portal where the provider's office can log in and find the patient right on the portal. and then be able to verify those benefits. So there are also other websites that that allow for online verifications and so on and so forth. And something like this, Navinet is one. There's one called Availity. There's just a number of them that you're able to log into to get information about a patient's benefits and find out what is covered and what is not covered. So I just wanted to show that to you, to show you the different resources that a front desk person or a biller will have at their fingertips in order to verify benefits and find out what that patient needs to pay at the time of service. So those are some of the main reasons why a front desk person would be afraid to collect up front because they don't know what to collect, but sometimes the front desk person is afraid to confront the patient. They don't feel comfortable asking the patient for money. And that goes to what we talked about a little bit ago, known as the poverty complex, is and you find this very, very prevalent with doctors who are right out of medical school. They have probably, almost $500,000 in student loans, and even though they're making good money, they're pretty poor because everything is going towards paying off their loans and paying on the clinic that they just bought, or paying into a clinic that they're buying, and so now they're and then they have staff people who they're not paying them a lot of money because they don't have a lot of money, and so it can be a real vicious cycle. And then you have this front desk person who doesn't make a lot of money and has to ask a patient for a bill, for $1,000 for a bill, and they have a hard time doing that. So number one is, the number one solution is knowing what to collect. I mean, if you know what to collect, you can be a lot more confident in asking the patient for money, but the rest of that needs to be worked on. So I want to give you a few tips if you feel like you either know somebody, a staff person, or you yourself are guilty of having a poverty complex. I want you to just think about a few things. One is think about the consumer. Think about the patient as a consumer. Consumers expect to pay for things as they're purchased, and so remember that. Nobody's going to go to the grocery store and get to the checkout counter and say, "Oh, sorry, I forgot my checkbook. I'll catch you next time." It's not going to work. That person expects to pay for those groceries, and they're not going to walk into that grocery store without their checkbook or their wallet. And if they do, like I have a few times in my life, I've very embarrassingly told the checkout person that, "Oh my gosh, I don't have my checkbook, and can I take my card and put it into the deep freeze, and I'll be right back." And I go home and grab my checkbook and pay my grocery bill. I have to come back. So you need to not take the patient's excuses and not allow those excuses to override the necessity to collect that money. So what do you say if the patient says, "Sorry, I forgot my checkbook," or "I didn't bring my checkbook"? In that case, if it's a copay, because they're supposed to pay before they see the doctor, then you can say, "Well, I'm really sorry, then we're going to have to reschedule your appointment," because you can do that. If it's a coinsurance and a deductible, and at the end of the visit they say, "I'm sorry, I forgot my checkbook," then you can say, "Well, that's fine. We're open until 4. You can come back." Make a note in the account that the patient stated that they didn't have their checkbook. Whether they come back or not, you don't know, but you can also call them up, or you can say to them, "Hey,
Okay, so we just had a little sound bite problem. So just remember that, you know, patients understand that when, generally, when they have a service, that it is expected that they pay for that service. So sorry, I forgot my checkbook is not a good excuse. You can always call them as soon as they get home, ascertain their checking account information over the phone, put it into a database such as Cash Practice or another PCI compliant database, and then let them know that they don't ever have to worry about bringing their checkbook again, that you'll automatically deduct the bill from their account when it comes due. Always keep the value of the services in the forefront of your mind, or meaning, or the front desk person's mind. I think that's very important. Your doctor spends a lot of money to go to school and to receive the education that they receive, and they have a lot of expertise in what they do, and the services that they're providing are valuable. They're keeping people healthy. They're trying to keep people from dying. They're trying to keep people at work. And so this isn't just, you know, chump stuff. This is a very, very valuable service that the patient is receiving. And you have to remember that, and you have to have your doctor's back when it comes to having the patient pay for those services. Know how to handle excuses. Make sure that the front desk has plenty of scripts and ammunition for handling patient objections. And role play during staff meetings or at the strategic planning sessions. So, you know, this is something that, you know, it's funny because I worked with a doctor many years ago who his office was way in the back of the clinic, and I was way up front at the front desk, and this is when I was still fairly new at all of this. And so what he would do is, if there were no patients around, he would call me. He would get on the next one extension and then call me on the other extension, and he would pretend to be a patient. And I mean, and sometimes he would be like really ornery with me, you know, and he'd try to be a patient and, you know, ask about why he should pay his bill, or, you know, he wanted to schedule an appointment and he'd be difficult about getting an appointment scheduled. And so, you know, at first I was uncomfortable with the process of this role-playing thing, but after a while I saw the value of it, because when it actually did happen, I was able to handle it. And so, you know, during staff meetings, you know, if you're a biller and you're having issues with your front desk, knowing what to collect from a patient, offer to do role play with them. Offer to have, you know, give them some tips of things that they can say and things they can do to improve the collection process. And for those of you who work with Gold Star, if you have clients who have staff people who are, you know, are uncomfortable collecting at the front desk, let them know that I would be more than happy to schedule a webinar with them, or a time to meet with them in their front desk to help them overcome these problems. I actually have a webinar called The Right Answers, and basically it's every excuse in the book and how to handle them. And so, and I do that and it's a great webinar for those front desk people to know how to handle difficult situations with scheduling and payment and so on and so forth. And remember that collections are always done with a smile. You know, don't show fear. I don't know if you know this, but if you grab an alligator by the tail and you grab it super firm, and you don't show any fear, that alligator will just sit there. They won't bite you. But if the alligator senses that you're shaking or that you're scared, they can sense it. They'll thrash, and they'll try to turn around and they'll try to bite you. And, alligator handlers know that. And that's why they can jump on those alligators and, and get them subdued fairly quickly because they're extremely firm with them. And so show no fear when it comes to collections. That's a really, really important concept. Here's another collection problem, and this probably is one of the bigger ones, is not having a consistent financial policy. And so obviously the solution to that is to develop one, and once you develop it, then stick to your guns. So some offices have a financial policy, but it's very, very nebulous. And it's not in writing. It's just kind of verbally given to the patient. The financial policy should be in writing. It should be simple. The front desk or the insurance department should always do a brief review of the patient benefits and the financial policy at the beginning of care, and it helps to handle potential problems with payment that day and then any payment in the future. And then make sure that there are available financial solutions for patients who may have difficulty paying their bill all in one day or all at once. Using auto pay options like an auto debit system with a debit card or credit card where they may pay a certain amount each week or each month. I would recommend for doctors who have fairly high fees to maybe consider for their self-pay patients to join a discount medical payment organization or a DMPO, and that allows you to have a fee schedule, a cash fee schedule that is legally compliant and meets all the requirements of a contracted fee schedule. There are credit cards that are designed for healthcare costs only, and the most popular one in the United States is called Care Credit. Most patients will actually qualify for even a small line of credit, maybe $500, but some of them are significantly higher. Like my family, we have Care Credit, a Care Credit card, and we have a $5,000 line of credit, and basically it is a way for the patient to pay out their bill with no interest. And so depending on the balance, the patient may have, to may be able to pay out that bill for over 12 months with no interest. Now the catch-all is they have to pay it out. They have to finish paying it within that period of time, or all the interest gets tagged on. So, that's the danger. But for the doctor, usually they have to pay an upfront cost to join Care Credit. I don't know if it's around $400 or so to join, but then once they've joined, if they accept Care Credit the same way they would accept Visa, MasterCard, or Discover, then what they can do is the patient, if the patient can't afford the care, they can do a quick app to see if they would qualify for Care Credit, and if they do, then they can set them up on a Care Credit plan, set them up on whatever Care Credit authorizes based on the bill. Sometimes it's 6 months, 12. I think the longest is 24 months. You can go up to 24 months with no interest. But then the doctor bills out the fees to Care Credit, and Care Credit takes a discount. I think they make the doctor take a discount of about 10% of that fee. But if it's a cash for a 10% discount is a whole lot better than nothing. So even though the doctor's having to take somewhat of a discount, it's legal, and at least they're going to get the majority of the care paid for. And then there is the true financial hardship, and occasionally you're going to come across patients who just say, I can't afford this at all. I'm on a fixed income, or I'm on unemployment, or I make $2,000 a month and I have a family of 5 to feed, and I can't afford can't afford $100 a month. And so in a case like that, you need to be able to go to the Department of Health and Human Services website and pull up the federal poverty guidelines. The website is on this slide, and based on that patient's income and household, you could qualify them for financial hardship and then basically either treat them for free or treat them at a very low cost. But financial hardship is something that has to be reapplied for every time they come in, or if they're coming in for like multiple visits in a month, at least once a month. They need to requalify every month, because if the next month they get a job and now they have insurance, they're no longer financial hardship. And I've seen doctors' offices who put patients on financial hardship, and they've been on financial hardship for 5 years, and in the meantime, they've gotten a new job, they have insurance, they have a new car, but they're still on financial hardship. So you need to make sure that the patients that are on financial hardship are true financial hardship patients. This is an example of a simple financial policy that you can go over with the patient at their first visit. It can be as little as 1 page long. Some of them are about maybe 2 pages long. But at the top of the financial policy would be a list of your most popular services you perform in your office, which would be like, and this one, it was for a behavioral health clinic that we do billing for. So it essentially has the, here's the fee for the new patient diagnostic eval, here's the 30-minute counseling session, a 45-minute, a 60-minute, etc. And these are what the fees are. And then it gives the criteria. So if the patient has insurance, this is what we're going to do. If the patient does not have insurance or limited benefits, this is what we'll do for you. If you're financial hardship, this is what we'll do. And then you'll notice that there's a place in the beginning of each of these paragraphs to check. So you would check the paragraph that applies to that patient. You would review it, and then the patient initials and you initial at the end of that paragraph that that's been reviewed with the patient, and then the patient would print and sign that. You would witness it, and the patient receives a copy of it, and you put a copy of it in the patient's file. And so this way, there's never any question about, well, the doctor never told me I was going to have to pay this. It's all in writing. It's all lined out fairly easily for that patient to understand. This is an example of an automatic payment authorization form. And this, you'll see it says here, I authorize, Apple Medical Clinic to automatically bill me for unpaid services. I choose the following terms. Okay, and this would be a one-time payment or billed monthly. It tells where the when the payment will be processed and the method of payment, whether it's a credit or debit card, auto debit from the checking account, or held checks. Now, you can do held checks. You cannot do post-dated checks. So just remember that. If you do held checks, I know some doctors' offices will do that, where the patient will write out 6 checks for the equal amount, and then the doctors will put those, or the doctor's office will put those in a safe place, in a locked safe or a locked drawer. And once a month, they just pull a check and deposit it. And that's another way of doing, kind of an old school way of doing auto pay, but it's still very, very effective. And sometimes the older patients who don't want to give out their credit card information, or they're not real tech savvy, they'll do the held checks. Now, the held checks, each check is dated for the same date. It's just a different check and a different amount. So, those held checks you can only do, I think at the most 6 at a time, because a check is only good for 6 months. And so, anyway. But this is just a form that you would have the patient fill out when you're doing some kind of a payment arrangement with them. What if you have poor payment habits? What if you have, over the years, or you inherit a client over the years, if you're a biller, that have created a monster when it comes to patient payments? And they've always been very lackadaisical about payment habits of patients, and the doctors recognize it and they want to do something about it. But at this point in time, they just don't know what to do. So the goal is to begin to turn it around. Draw a line in the sand. Basically, what I advise doctors to do, if maybe they purchased a practice and the old outgoing doctor never made their patients pay a copay. Now all of a sudden this new hungry doctor that has to pay for this practice has to have the patients start paying. Well, how do you do that without losing the patient? So basically what you need to do is draw a line in the sand by posting a new financial policy notice. You keep it simple. If you have patients that comment, well, I never had to pay before, then ask them if payment would pose a financial hardship. And if they say it is, then try to have them pay something. Remember, going back to the very first item was, if you don't know what to collect, collect at least something. Have them make a partial payment and set up auto pay option for the remaining balance. Always be understanding with these patients. I understand, however, Mrs. Smith, your account has now reached a level where you might compromise your health because you have this big balance, and patients like yourself are usually so nice they'd rather not come in when they have a balance, and we don't want that to happen. And so I'm sure you don't either. So let's see what we can do together. How much could you pay? Right? And you start working with that patient to get them to pay down that bill, and do it through some type of an auto pay option so they don't even have to think about it. You set it up, and then every month you just process that credit card, or you deposit that held check, however you would want to do that. And make sure that every month you're sending out monthly routine patient statements so that patients always know where they are. This is an example of a sign that you could put at the front desk. So if your front desk person is or your clinic policy is wanting to turn it around and do better at patient collections, this would be a letter that you could put up at the front desk. And basically, I always say blame it on Obamacare. Due to regulations that are being enforced as part of the new healthcare system, our office must now collect payment for non-covered services as they're rendered. This will include payment of services for patients with no insurance and patients who have insurance but are required to pay a copay, coinsurance, or deductible. Extended payment options may be available to patients who qualify. Please see the front desk for more information. And thank you for your continued support of our clinic and your patients as we complete this transition. So you see, this is not, like hard nose. It's just saying, hey, this is what is happening. We're making some changes. There's a new sheriff in town, and now we've got to begin to collect at the time of service. So that concludes our patient collections portion of the class. Let me see if I've got any questions here. What is ROF? Oh, sorry, Dawn. ROF is a report of findings. That is that when you present a treatment plan to a patient. So if you're presenting the patient with a treatment plan and you already have the patient's insurance verified, then you can give them an estimated cost of care based on that treatment plan. Let's see if there's anything else. Dawn says they will argue with you. They don't want to transfer you. Ask for an English-speaking supervisor. I think that goes back to the insurance verification class. Yes, they will. Some will. Some won't. They're okay. It just really depends on the insurance company and who you're talking to. But yeah, I mean, sometimes there's going to be that language issue. Let's see. I think those are the only other questions. Now, you all, if you want to, you can come off of mute. And if you have any other questions at this point, you can go ahead and ask them. No questions? Everybody wants to call it quits and go to bed, yeah? I know I do. Okay, well, I'm going to finish up this recording then. Thank you all for coming. And on Wednesday, we're going to be talking about revenue cycle management and working on bringing accounts receivables into compliance and management, and working on tracking claims that don't get paid. So really kind of getting into the heart and soul of what you do as a medical biller. So hopefully you don't miss it, and we'll see you on Wednesday. Thanks, everyone.